Muchas gracias.
Recording in progress.
Bueno, buenas tardes a todos. Son justo las 5 de la tarde y vamos a empezar esta quinta reunión CMV Global que organizamos el profesor David Navarro, jefe del Servicio de Microbiología del Hospital Clínico de Valencia, y yo mismo, José María Aguado, que soy el jefe de la Unidad de Enfermedades Infecciosas del Hospital Universitario 12 de Octubre de Madrid. Ante todo, daros las gracias por haberos inscrito a esta reunión. Sois aproximadamente 50 personas hasta este momento las que estéis inscritas, pero esperamos incluso algún número mayor de asistentes. Explicaros cuál es el objetivo de CMV Global, que es hacer una serie de reuniones periódicas, las que, como digo, esta es la quinta ya, en el que revisamos temas relacionados con la infección por citomegalovirus, algunas de ellas o de forma preferencial, no, digamos, menos conocidas por la audiencia. Se han hecho revisiones, por ejemplo, de la transmisión materno-fetal, CMV, del papel de este virus en el cáncer, por supuesto, del papel que tiene en el trasplante de órgano sólido, pacientes con trasplante de progenitores hematopoyéticos, y la verdad es que han tenido un gran éxito hasta este momento. El tema elegido para hoy ha sido la respuesta celular T en el manejo de la infección por citomegalovirus en el trasplante de órgano sólido y en el trasplante de progenitores hematopoyéticos. Y bueno, contamos con dos personalidades en este mundo, que son el doctor profesor Chemali y el profesor Manuel, que serán presentados posteriormente. Tengo que decir que estaba previsto inicialmente la participación del profesor Ajit Limaye de la Universidad de Washington, en Seattle. Desgraciadamente, ha tenido un problema familiar y con muy poquitos días se ha excusado, y afortunadamente y muy amablemente el profesor Oriol Manuel ha aceptado participar esta tarde, lo que queríamos agradecerle de manera especial. También agradecer a MSD por su patrocinio para la realización de esta reunión. El tiempo previsto para cada una de las intervenciones será de 20 minutos y la discusión se hará de forma global también durante unos 20 minutos al acabar las tres presentaciones. Podéis hacer las preguntas que creáis oportunas a través del chat que tenéis disponible, y de hecho pues agradeceríamos enormemente que así lo hicierais. Las tres presentaciones, digamos que por delicadeza con el profesor Chemali, van a ser en inglés, porque de otro modo pues no iba a poder participar, y le hemos pedido a Oriol que la haga también en inglés, y el profesor Navarro también la hará en inglés. Las preguntas, sin embargo, las podéis hacer en español, y les haremos la traducción al profesor Chemali si fuera necesario. Bueno, a continuación ya solamente darle la palabra al otro coordinador de esa reunión, que es el doctor David Navarro, y presentarle o presentar ya el tema que va a hablar. El tema es la evaluación de la respuesta específica frente a CMV en el manejo de la infección por este virus en el marco del trasplante, y cuál sería la aplicabilidad clínica potencial que tiene esta técnica microbiológica. Entonces, sin más, David, te paso la palabra. Muchas gracias.
Muy bien, muchas gracias, José María. So thank you, José María, for your kind presentation. And let me thank again both Roy and Oriol for joining us today. It's a real pleasure for us to have you here today. So actually, I'm acting as a support actor basically here. So the guest stars are Roy and Oriol. That's for sure. So my idea is to provide some background so you can follow properly Oriol's and Roy's presentation. So let me start by saying that, as you probably know, CMV-specific CMV immune response or control of CMV infection depends on the interplay between innate and adaptive immune mechanisms. So we know for sure that early control of CMV replication depends upon the activation, basically, of NK cells that produce functional cytokines such as interferon gamma. However, definite control of CMV replication depends upon activation and expansion of T cells, basically, although there are other cell subsets which probably intervene somehow in providing control of CMV replication. I'm speaking about T gamma delta cells, for example, and also T regulatory cells. We are not sure whether B cells producing functional antibodies play a crucial role in providing protection against clinical significant infection and organ disease in transplant recipients. So let me conclude that the immune response against CMV, particularly in immunosuppressed recipients, is rather complex, that's for sure, but also probably redundant. That's an important key feature of the immune response against CMV, both in healthy, actually, and immunosuppressed patients. So we know that T cells are determinant in the control of infection. We have known this for a very long time. This is a pioneer work conducted by Stanley Riddle's group in 1995, in which they show for the first time that adoptive transfer of T cells with cytotoxic ability was capable of controlling the development, preventing actually the development of CMV viremia and end organ disease. So we know now that at least 70% of the CMV proteome is targeted by functional CD8 T cells, at least in healthy individuals. This is a pioneer work also performed by Sylvester and colleagues 20 years ago. Basically, they show nicely that, as I said, almost 70% of the proteome of CMV was targeted by CD8 T cells. But what we know also for sure is that the spectrum of proteins which are recognized by CD8 T cells may vary across individuals. But nevertheless, PP65, which is, you probably know, a major tegument protein, thus it is a structural protein, and also IgE1, which is a non-structural protein, which is expressed early following infection of cells by CMV, are immunodominant in most individuals. However, the contribution of most of these CD8 T cell responses, other than those targeting PP65 and IgE1, in the control of CMV infection is largely unknown. This is a work that was conducted by Paul Moss' group a long time ago also. They show nicely that adoptive transfer of CD8 T cells targeting specific epitopes within P50 was capable of controlling viremia that was nevertheless refractory to treatment with conventional antivirals. Actually, they transferred, as you can see in the upper figure, they transferred CD8 T cells recognizing this HLA-O2 presented peptide NLB, and as you can see, adoptive transfer and expansion of in vivo of these cells was capable of controlling viremia. They did the same experiments using different T cells, CD8 T cells, recognizing different epitopes within PP65. We also know that CD4 T cells are essential in the control of CMV infection. They perform an indirect role by providing adequate activation and expansion of CD8 T cells, recognizing ortholog epitopes, but also CD4 T cells may lie CMV infected cells expressing HLA class II molecules. That happens in vivo when endothelial cells are infected by CMV. Also, 60% approximately of the CMV proteome is targeted by CD4 T cells. And as for CD8 T cells, there is a wide variation across individuals regarding what proteins are immunodominant. But nevertheless, we may say that PP65 and GB are particularly immunogenic for CD4 T cells. Well, nowadays it's quite easy actually to enumerate CMV-specific T cells ex vivo. So we use flow cytometry-based assays, including surface and or intracellular cytokine staining, or HLA peptide multimers, or we may use the so-called interferon gamma release assays, or IGRA, which includes the ELISpot and the quantiferon CMV assay, among others. So it has been considered that flow cytometry-based assays, particularly surface and intracellular cytokine staining assays, are the gold standard. Actually, I'm not sure about that. I don't know what Roy and Oriol think about it, but in my opinion, there are so many different protocols of these sort of methods that, and the lack of standardization make this assay unlikely to be the gold standard, in my opinion. So let me go through all these methods briefly so I can give you a background of them. So beginning with the surface and intracellular flow cytometry assays, for sure, these assays are highly sensitive. They allow enumeration of different functional T cell types, for example, whether cells recognizing CMV epitopes are mono or polyfunctional, that is, they produce a single cytokine upon stimulation, or they produce several of them, whether they express homing receptors, or whether they are activated, or whether they are exhausted. So you may have a comprehensive picture of CD8 or CD4 cells recognizing CMV antigens by using this method. No knowledge of the HLA haplotype of patient is required for performing these assays. It allows measurement of both CD4 and CD8 T cells, and allows likewise assessment of single or multiple epitope specificities. Well, depending on what kind of antigen you use, you may prime CD4, CD8 T cells, or both. Commonly, many protocols use as the antigenic stimulus overlapping peptide. That is, there's a collection of 15 mer peptides with a 11 amino acids overlap, which usually expand the entire sequence, most frequently of PP65 or IE1. By using overlapping peptides, you may prime both CD8 and CD4 T cells. That's why this strategy is used in many flow cytometry-based assays. Alternatively, you may use single peptides, usually short ones, or mixes of short peptides. In that case, you are priming essentially CD8 T cells. You may alternatively use lysates of infected cells, or purified virions, or recombinant proteins, which prime mainly CD4 T cells. Most flow cytometry-based assays, as I said, are designed to detect CD4 or CD8 T cell responses against PP65 or IE1. There is a more complex protocol which are commonly used by Italian groups, which use infected dendritic cells infected using macrophage tropic CMV, and they use these infected cells as the antigenic stimulus. This method, which is quite cumbersome, permits a very comprehensive assessment of T cell responses against CMV. But I will not go any deeper on this. Of course, you may use peptide HLA multimer assays. Actually, I don't think many people are using these assays nowadays, but in any case, these are commercially available. They're simple to perform and sensitive. By using peptide HLA class 1 multimer assays, you detect CD8 T cell recognizing specific epitopes. Unfortunately, you need to know the HLA haplotype of the patient you are going to monitor to use the right peptide HLA multimer. Unfortunately, no information on T cell functionality can be derived by using these assays unless you couple them to surface or intracellular cytokine staining, but it allows the assessment of single epitopes specific for CD8 T cells or multiple epitopes, if you combine different pep mixes. As I said, these assays, or some of these assays, are commercially available. They use what we call dextramers. These dextramers have a higher ability for TCRs. They provide a better fluorescence signal and are highly stable. We don't used to use HLA class 2 peptide multimers due to their instability, actually. Regarding eGRAS, we either may use the ELISpot assays. There are 2 ELISpot assays, as far as I know, that have been commercialized, the T-spot and the T-track assay. And also you may use the quantiferon CMV assay. Briefly, with the ELISpot, what you do is you separate PBMCs and you incubate these PBMC cells with the antigenic stimulus that you have chosen. So the thing is that after incubation, the cells are plated in a 96 well plate, and those cells that have been activated and produce interferon gamma are captured by using a monoclonal antibody against interferon gamma, which is bound to the plate. So each spot in this assay represents a single cell that has been activated by the selected antigen. So the ELISpot assays are functional assays. Commercial assays use either PP65 and IE1 peptides or truncated proteins. No knowledge of the HLA haplotype is required to perform the assay. But unfortunately, unless you select for a specific antigen stimulus, you cannot discriminate between CD8 T cells and CD4 T cells. Furthermore, in addition to C cells, these ELISpot assays measure NK and NKT cells, which are activated by antiviral, by immunoregulatory cytokines. And other assays that I am talking about, the ELISpot assay allows assessment of single or multiple epitope specificity. The quantiferon CMV assay is a well-known one, which has been in use for several years now. But actually, what this assay allows is to detect CD8 T cell responses against 22 peptides, which are mapping within these proteins, PP65, IE1, IE2, PP50, which is another matrix protein, and the surface glycoprotein B. This is a functional assay as long as it detects interferon gamma. But basically, you use whole blood, which is incubated with this mixture of peptides, and then you, by using an ELISA assay, you quantify the amount of interferon gamma which has been released by activated T cells. This assay, as well as the ELISpot that I referred to earlier, is highly standardized and does not require special equipment. So the characteristics of these assays has been nicely reviewed by Oriol, Manuel, and others in this paper, which I recommend. So let me just point out that there is a flow cytometry assay which has been commercialized. It's called the Veracor, and I think Roy is going to talk about it later on. So the thing is that how do CMV T cells assays compare? Well, at least in allogeneic stem cell transplant recipients, as far as I know, there are 2 studies which have assessed how these assays compare to each other. In this first one, the upper panel, the quantiferon was compared to the T-spot CMV assay, and in the lower panel, this study was performed by my group. We compare the quantiferon CMV assay with our in-house flow cytometry-based assay. Sorry. I don't know what I did. So This is side-by-side studies assessing how these T cells assays compare in solid organ transplant recipients. This paper up there, which was also performed by Jose Maria, my group. And then there is this another one which compared the ELISpot with the quantiferon CMV assay. So just summarizing, in my view, there is a relatively good qualitative concordance between all these assays, the ELISpot probably being the most sensitive one, even more than flow cytometry, or at least than some protocols for flow cytometry. However, from a quantitative standpoint, the correlation between quantitative levels measured by these assays is low to moderate at best, at least in my experience. So several markers for protection against clinically significant infection, clinical significant CMV infection have been proposed, but in my opinion, the best one that includes many, including polyfunctional CD8 or CD4 T cells, but there is a lot of clinical evidence suggesting that detection, quantification, of interferon gamma producing CD8 or CD4 T cells are probably the best markers for protection against clinically significant CMV infection. In fact, several thresholds for protection have been proposed using flow cytometry-based assays. Those are in these slides. As you can see, interestingly, most of these cutoffs are within a very narrow range of cells per microliter, between 1 and 3 T cells, CD8 T cells, or 1 and 2 CD4 T cells. As for cutoffs providing or predicting protection against clinical significant CMV infection, as determined by the ELISpot and the quantiferon assay, probably Roy and Oriol will get a little bit deeper on this. In my view, the thing is that cutoffs predicting protection against clinically significant CMV infection need to be validated in prospective intervention multicenter studies, recruiting homogeneous cohorts and establishing optimal timeframes for monitoring. This is particularly so in allogeneic stem cell transplant recipients. So one of the things I wonder is how well do represent ex vivo data gathered by using these methods, how well these figures represent what is really going on in vivo, particularly in patients that are highly immunosuppressed, for example, in allo-SCT recipients developing severe graft versus host disease that requires high doses of corticosteroids. And of course, I mean, the predictive values for prediction, the predictive for clinical significance investigation are, in my view, suboptimal, particularly again in allogeneic stem cell transplant recipients. So this is a paper, it's an editorial that was published by Per Lundman a long time ago in 2006, in which he invoked combined virological and immunological monitoring for individualizing preventative strategies against CMV infection, either using preemptive antiviral therapy strategies or prophylactic strategies. Well, the thing is that there are several potential intervention strategies based upon immunological monitoring that may work, both in allogeneic stem cell transplant recipients and in solid organ transplant recipients. I don't know why. Sorry, again. So these are, in my view, you may, for example, defer antiviral therapy when you detect CMV anemia if at the same time you are capable of detecting CD8, CD4, or both T cells against CMV infection above a certain level, predefined level. So in our hands, this strategy doesn't work. There was a paper published by Per Lundman group that seemed to prove that this strategy may work in certain subgroup of patients. There is another strategy that it works in our hands, which is for patients who are under preemptive antiviral therapy, you may interrupt early antiviral therapy if you are capable of detecting CD8 T cells or CD4 T cells or both above a certain threshold. And there is a third strategy in which we have no experience at all, which could be this one. After CMV anemia clears, you probably may maintain antiviral therapy if CMV-specific T cell response have not been developed at that time. So sorry. So regarding the second strategy, this is a pilot study we published just a few years ago, in which we showed that this strategy, which remind you, consisting of suspending antiviral therapy if you were able to detect interferon gamma producing CD8 T cells above this threshold, 1 cell per microliter, and you were capable of showing at the same time the CMV DNA load was decreasing and decreased actually to lower levels than 100 copies per ml. By using this strategy, we were capable of reducing the duration of preemptive antiviral therapy courses, and also we decreased the incidence of recurrent episodes compared to conventional strategy. But unfortunately, this strategy did not work in patients with severe grades 3 and 4 acute graft versus host disease. So we performed an intervention study based on this strategy, and we showed that it worked nicely, but only for 20% of patients in the cohort. We used a historical cohort as a control group. We were capable of suspending anticipatedly preemptive antiviral therapy only in 20% cases, but these patients had not higher level of recurrences after conducting this strategy. So the strategy works, that's for sure, but only in a very small subset of patients, and definitely does not work in patients with severe graft versus host disease. So there is another strategy that could be in place, short enough, which is measuring CMV-specific T cell responses at the end of letter-mobile prophylaxis in allo-HSCT recipients again, and then decide whether to extend or not letter-mobile prophylaxis depending upon what you measure around day 100 after initiations of letter-mobile therapy. So if we are capable of detecting specific CMV T cell responses, you probably do not need to extend prophylaxis, but the other way around. If you are unable to detect them, maybe it could be safer to prolong letter-mobile prophylaxis. There is no clinical trial, as far as I know, proving that this strategy is cost-benefit. Well, that's what we said regarding management, immunological management of allo-HSCT recipients in the ESIL guidelines published actually in 2019, if I'm not wrong. This corresponded to ESIL 7. So we were quite there at that time. So we were saying basically the sequential monitoring of these CMV-specific T cells may provide useful information for the management of CMV infection, but we did not go any further. In the recent ESIL guidelines, Roy and I, we wrote something more proactive, actually. So what we recommended was that sequential monitoring of interferon gamma CMV-specific T cells may provide useful information for the management of infection, which is basically what we said in 2017. But we suggest that the main applications of these assays may include extending or shortening the duration of primary LNP prophylaxis or withholding therapy when low-level viral loads are detected, and also to identify patients that may benefit from secondary LNP prophylaxis. And as our third recommendation, we support the use of commercialized, we prioritize actually the use of commercialized assays that are standardized to be conducted in studies addressing this issue rather than in-house developed protocols. We can comment on that later on in the Q&A part of the meeting. Regarding solid organ transplant recipients, I mean, there are three scenarios in which we can use these assays, the results provided by these assays to manage optimally those patients, which is using these assays for stratifying the risk of patients at baseline, for modulating the duration of preemptive antiviral therapy, and also antiviral prophylaxis. But I'm sure that Oriol will give you some more details on these potential strategies. Also, I'm sure that Oriol will comment on this. This is consensus guidelines in the management of CMV infection in solid organ transplant recipients, which was published by this Spanish group, in which there are several recommendations regarding the use of these assays in the context of solid organ transplantation. So this is my last slide. So immunological monitoring in the management of CMV infection in transplant recipients, the question is, are we there yet? So do these methods are these methods being used currently in clinical practice worldwide, or do we need more intervention studies before these methods can find their spot in the management of CMV infections in these patients? So we will have the chance to discuss this, but in my view, actually, I think we are close to it, but we are not there yet. So thank you for your attention. And now let me introduce Roy Chemali, a very good friend of mine. Roy is many things. Just correct me if I'm wrong, Roy. So he's director of the Clinical Virology Research Program at MD Anderson Center in Houston, Texas. And he's also professor of medicine at Baylor College of Medicine, also in Houston, Texas. So Roy, whenever you wish.
Thank you. Thank you, David, and thank you, Jose Maria, for inviting me today for this very nice symposium. And thank you for the introduction. Actually, that's great. I'm gonna try to complement what you started, David, with the nice overview and where we're at today. So I'm gonna share with the audience our experience. Let me see if it's working. Okay. Can you see my slide or no?
Yes, I can see.
You have to enlarge one. Just
Enlarge.
try to make it bigger. To full screen, you know?
Yeah, I'm trying to make it full screen. Let's see.
Yeah, down there. Yeah, right.
Okay. Is it better?
Yeah.
How it works.
Yeah. Okay. So, yeah, thank you. So it's a nice segue to share with you our experience. Where we at in allo stem cell transplant recipient? These are my disclosures. And first, let's talk a little bit about the burden of CMV post-transplantation. We all know that viremia, CMV viremia, it is bad news. And the main reason initially, what we learned for many decades, that this viremia, if it go out of control, it's gonna progress to CMV and organ disease, unless we do something about it. Either we do preemptive therapy, we treat, or we try to prevent CMV viremia. And the most common end organ that could be affected, either the GI tract or the lungs causing pneumonia, but also other organs that we tend to forget, could be CMV retinitis. Sometimes we may see CMV ventriculitis or other organ affected by CMV. But what is also important is the indirect effect of CMV being CMV seropositive after transplant, or even having a little bit of CMV viremia. It may affect the immune system in a negative way. There is some data showing that CMV could, lead to graft rejection in solid organ transplant recipient. But what about GVHD, or graft versus host disease, after allogenic stem cell transplantation? CMV by itself can lead to further immunosuppression. Actually, it's a big immunomodulator virus that we have big respect for. Actually, it can have a high impact on our patient population. There is good data showing fungal and bacterial co-infection may occur when patients have CMV reactivation. But non-relapse mortality after allotransplantation, it's becoming something that we keep an eye on. And there is good data out there showing that any CMV viremia may increase the odds of non-relapse mortality compared to patients who didn't have any viremia after allotransplantation. Management of CMV, it is sometimes difficult with some trades-off between how is the optimal immunosuppression to manage graft function and prevent rejection in solid organ transplant, but also prevent end organ disease in allotransplantation, and that may lead to CMV and organ disease. So the management could be sometimes pretty difficult. Now, the burden also of CMV is controlled by two factors, mainly viral factors versus host factors. And this what lead to CMV pathogenesis, the imbalance between these two major factors. For viral factors, we looked at replication dynamics. We looked at the immune evasions of CMV by our immune system. The viral heterogeneity sometimes play a role, but also viral co-infection. So if at high risk for CMV reactivation, you could be also at risk for other viruses like HHV6, for example, or even EBV. Host factors play a big role in trying to lessen this, the burden of CMV. If you have good CD4 and CD8 T cell responses to CMV, you may control it in a better way, have impact on progression of CMV infection, but other orthopathway from NK cell, B cells, sometimes exogenous, and actually most of the time exogenous immunosuppression play a big role. When you have patient on very high dose steroid for severe GVHD, this gonna put patient at risk for CMV reactivation. And of course, the donor and the recipient immune status and the mismatch between the two will contribute to the burden of CMV in our patient populations. Fortunately, for many decades, now we are at a point, we had some major advances in CMV management. First, when we talk about diagnosis of CMV reactivation, I remember during my fellowship, we're looking at shell vial cultures and CMV antigenemia. And over the past 1 or 2 decades, now we moved to molecular testing or molecular assay. Now we have quantitative PCRs that give us better idea, more sensitive and also more specific, and how bad it is the CMV reactivation, depending on the viral load measurement as well. We're talking about CMV cellular-mediated immunity, and I think this is some of major advances that we try to identify or to show the role of this new tool, which is measuring CMV cellular-mediated immunity with different tests that David talked about. How this will help us at the bedside to determine if patient need to be treated or not, to stop prophylaxis. And I'm going to touch up on few areas that it could be helpful for us to measure CMV, CMI, and improve management at the bedside. The other advances that I'm not going to talk much about it is now we have a new oral and IV and safer drug that is used for prophylaxis, which is letermovir, that most of you are probably familiar with, that we were successful around 7 years ago to bring it to the market. And there is shifting in preventive surgery from preemptive therapy to prophylaxis now, at least in hematopoietic cell transplant recipients. Another new drug that it is on the market over the past 2.5 years now, which is maribavir, and it is used for difficult to treat CMV infection, mainly patients with resistant and or refractory CMV infection. At least we have now another option that we can treat our patient with, which is an oral drug, and it's also safety-wise, it is better. It has much better safety profile than the one available that we've been used for many decades, which are again cyclovir and foscarnet that you are all familiar with. Two different strategies, prophylaxis versus preemptive therapy. As I mentioned earlier, in allogenic stem cell transplant recipient, but now the trend, it's more for prophylaxis instead of preemptive therapy for many reasons, because we have a new drug which is safe and available, and hopefully we have access to it in most transplant centers. But there is some pros and cons between the two strategies. For prophylaxis, letter movie worked very nicely, but we know that it may delay CMV-specific immune reconstitution, because when you prevent CMV viremia, you prevent antigen exposure to T cells, and you're going to have probably delay in T cell reconstitution for CMV. But preemptive therapy, what we learned over the past 5 to 10 years, there is concern for survival disadvantage in someone who had CMV reactivation versus the patient who do not. And the reason is actually because of probably multifactorial, probably the indirect effect of CMV. So allowing CMV to reactivate in order to get treated, it may put patient at survival disadvantage. And there is good data showing that non-relapse mortality is higher in patients who get CMV viremia versus patient who did not. Even recipient negative had better survival than recipient positive after allo transplant, and for many reasons. So how to increase specificity of preemptive therapy or prophylaxis strategy in the, at the present time? Is it combining viral load with monitoring of CMV-specific T-cell immunity that Dr. Navarro touched up on earlier? Would this will be a good strategy to help us manage and mitigate the risk of CMV infection at the bedside? Would also the strategy allow withholding prophylaxis in the presence of CMV-specific T-cell responses? We know now that Liturmovir was approved for CMV prophylaxis up to day 100 initially. Then we find out that now we're having late CMV reactivation. So what about up to day 200? And there is now it's indicated up to day 200. But after you stop, prophylaxis, are we also putting patient at risk for CMV reactivation beyond day 200? So how long is enough in order to be able to extend duration of prophylaxis? But would this tool, when measuring CMV-specific T-cell responses, help us to determine who need to be on prophylaxis at any time point after day 100 maybe, or even a little bit before day 100? Another also venue, which is allowing, would the strategy allow withholding preemptive therapy in patients with low to moderate level of CMV DNA or CMV viral load, and when you have a good CMV T cell response? And why I'm bringing this up, because as we all know, with the good, the measuring CMV viral load with molecular acid becoming more and more sensitive, now we can detect as low as 34 IU per ml, at least in our lab, but it could be even less. But what does it mean clinically? If you have patient with positive CMV viral load at 34.2 IU per ml or even 100 IU per ml, do we need to treat or not? Would this patient progress to higher level viral load or to progress to CMV and organ disease? So would measuring CMV CMI, would this help us to withhold therapy or to treat early on, even before patient progress? So I think I'm going to try to answer some of this question and show you or share with you some new data that we have. So CMV-specific CMI assay, David did a very nice, overview of what's available out there and what to do and which are standardized or not, and probably, access to commercially available assay. And we know the principle behind this assay. I'm not going to go over what David went over previously. Let me start by bringing a few questions from this case that most of us probably encounter on a daily basis in our practice. A 45-year-old woman with acute myelogenous leukemia, patient has high-risk cytogenetics, underwent haploidentical transplantation from her 20-year-old daughter. Recipient is CMV seropositive, donor CMV seronegative. So we're talking about D minus R plot, the highest risk situation for CMV reactivation. Conditioning regimen, as you see here, from flu-cy to single-dose TBI and post-cy to prevent for CGVHD prophylaxis at day +3 and +5. Patient did well, engrafted by day 18, discharged home on tacrolimus by day 30, and this is our practice at MD Anderson in Houston. What do you tell patient when she asks about her personal risk of developing CMV infection or disease? Because we talk to patient early on about CMV, because this is probably the most common infection that we may encounter after allogenic transplant in this patient population who are recipient positive. It is likely around 60%, or the risk is negligible because she's not on steroid for the time being. What about measuring CMV cellular-mediated immunity can predict the risk of CMV infection after allotransplant, or none of the above? It's not a polling question, but I want you to think a little bit about this question, about the answer as well. And probably most of you already guessed that measuring CMV CMI may predict a risk for CMV infection. There's quite a good studies out there after allotransplant showing that depend on which test you use, that it can really predict the risk of CMV infection if you have negative CMV cellular-mediated immunity. So let me go over, the prediction, the CMV CMI as a prediction tool for CMV reactivation, and especially when we talked about clinically significant CMV infection. We're not talking about very low level of CMV viral load. This is the definition of clinically significant CMV infection is when it required preemptive therapy and treatment. So, so this reactive study, which we published in 2020, but I have some updated data from last year, where it is a multi-center prospective observational study, collected the blood specimen up to 14 days before transplantation, but also every 2 weeks up to 6 months. And we performed the ELISpot CMV assay in this situation with the T-spot CMV as well. And we enrolled 250 patients. It was an international study. 9 were excluded for different reasons. We end up with 241 patients. We followed for 6 months, and 29% or 70 patients end up with clinically significant CMV infection. And we tried to correlate the T-spot assay or the ELISpot assay with patients who had clinically significant CMV infection versus patients who did not, which is 71%. And when we looked at we did the analysis a little bit different than the original analysis for the REACT study, where we were interested to see, would baseline testing before transplant and then at week 2 or week 4 help us to predict who will be at risk for clinically significant CMV infection, but also would this predict who is at higher risk of dying or all-cause mortality within 6 months from transplant? If you look at the upper graph, the 2 upper graphs, we're looking at the negative changes in IE1 and PP65 together from baseline to week 2 on the left side, or baseline to week 4 on the right side. And the dark spot that you see here on the graph are patients who had clinically significant CMV infection, and the blue one, the lighter one, the one who did not. You see that the dark spot are all on the negative side on IE1 and PP65, meaning there is a negative change from baseline where they had good CMV CMI, and then at week 2 or week 4, it dropped. Then they become at higher risk of clinically significant CMV infection. And what's more interesting, if you look at the bottom graph, the red dots are the one who died within 6 months, all-cause mortality. And we found also the same thing, that the negative changes from baseline to week 2 or week 4 on IE1 and PP65 together put patients at higher risk of all-cause mortality within 6 months of transplantation. So I think for now, we already answered the question that yes, it is a great predictive tool at least the ELISpot assay, and there's data for the interferon and flow cytometry to predict who will be at risk for CMV infection, but also who may die, not from CMV, all-cause mortality within 6 months after transplantation. So let's go back to our case, the 45-year-old woman of the AML. So we started patient on letermovir, 480 milligrams once a day because she's on tacrolimus for CMV prophylaxis at day +5. This is our protocol since for the past 7 to 8 years now, or 7 years since 2017, at day +5 for transplantation in patients who are recipient positive, of course. But at day +33, routine surveillance, we continue doing surveillance with CMV viral load on a weekly basis. CMV viral load was positive 470 IU per ml. Absolute neutrophil count 1050, absolute lymphocyte count of 250, and patients completely asymptomatic. That's what we see in daily practice. No fever, malaise, or other symptoms is different than solid organ transplant. So my question to you, what would you do next? Would you start preemptive therapy with oral Valgen or IV ganciclovir? What about preemptive therapy for IV foscarnet? Because it's too early after transplant, you don't want to use ganciclovir. What about preemptive therapy only if you repeat CMV viral load is above 500 IU per ml? No therapy is indicated. I wish I have more information, or any of the above. Give you a few seconds to think about the answer. What would you do in your practice? And this is pretty common. We see it quite often, even in the era of letermovir. I think the answer, as you all guess, probably any of the above. Because if I ask 10 people, what would you do? They could have different answers. And depends how conservative you are in your institution, or how anxious you are when when you are at the bedside, and you may treat or you may not. But I wish I had more information. And this is the issue that we have with low-level viremia. So what about measuring CMV CMI? Would this help us to predict CMV reactivation or progression of low-level viremia, especially in the era of primary prophylaxis? Today is different than 7 years ago or 10 years ago, because now we have to factor in the use of letermovir for prophylaxis in our patient population. So how the low-level viremia will progress, in the era of primary prophylaxis. We know that as soon as you stop letermovir at week 14, this is the landmark study, the phase 3 study that led to the approval of letermovir for primary prophylaxis after allo transplant. We know as soon as you stop it, some patients on the letermovir arm reactivated their CMV more so than when they were on preemptive therapy, which is the placebo arm, in high-risk or low-risk patients. And these patients, why they reactivated? Because they were still at high risk of CMV reactivation. So as soon as you stop letermovir, they reactivated. And also we know from study coming from Fred Hodge from Seattle, one of the first study, that a patient on letermovir, they have lower polyfunctionality scores for CD8 and CD4, meaning they had low CD4 T cell response, CD8 T cell responses when they stopped letermovir, compared to patients who were on preemptive therapy. So we are delaying probably CMV immune reconstitution when we put patients on primary prophylaxis, and this has to do because we're not allowing CMV to reactivate, and we're not, having antigen exposure to T cell, or T cell get its antigen exposure in order to produce, CMV specific T cell. So this could be the reason. So we are delaying it after day 100, and that's why we may get late CMV reactivation or infection or end organ disease with this practice. And now we extended up to day 200, but also when you stop it at day 200, some patient gonna still reactivate after stopping letermovir. So how this extra tool, which is the CMV T cell immunity panel, or CMV in the cell immunity responses, can help us to predict patients who have low-level viremia, even if they were on letermovir or not, would they progress to clinically significant CMV infection? So I'm going to share with you data that we didn't publish yet. It's in the making, and show you some preliminary analysis. We used a commercially available test that David touched up on earlier from Virac or Eurofins. It is, at least it's available commercially in the US. And the only one, to my knowledge, available, which is the CMV T-cell immunity panel using flow cytometry assay. You submit to them, and they will test it for you. They give you the result within 48 hours. So we were interested, and there were no clinical data so far. And that's why that's why we would, we conducted this trial, and we're doing also more in order to see what the value of this panel. Because as David cautioned you, be careful which assay you're using, because some assay have clinical data, some did not, and you cannot compare apple to oranges between the assays unless you do head-to-head comparison. So that's why we were interested to see, can we produce some clinical data? Is this CMV TCIP, we call it, is it useful for patients? And we start asking the first question about low-level viremia. So it was a prospective cohort study in allogenic stem cell transplant recipient with low-level viremia. Primary endpoint of the study was the rate to see the rate of progression from low-level viremia to clinically significant CMV infection, meaning initiating preemptive therapy at a little bit higher CMV viral load. If they were on letermovir, what the rate of progression versus if they were off letermovir based on this assay. And we were interested in secondary endpoint like cancer relapse, CMV and organ disease, or all-cause mortality up to 6 months from enrollment. I'm not going to share with you the data on secondary endpoint because it's still under analysis. So we enrolled 90 patients, allotransplant recipient with low-level viremia. 4 patients withdrew from the study, 1 screen failure. So we end up with 85 patients who completed 2 months of follow-up for now. Actually, we're analyzing the data at 6 months. 28 patients were off letermovir, 57 were on letermovir when they had low-level CMV viremia. This is a characteristic of the patient at enrollment. As you see here, not much of difference between the off letermovir or non-letermovir, except a median time from transplant to CMV activation was shorter for patients who were on letermovir. So they had breakthrough early on, and if they did not, they didn't have breakthrough later on. And off letermovir, it was longer, 159 days as a median time to reactivation or to have low-level viremia. So when we looked at the 57 patient with low-level viremia while on letermovir, we did the TCIP up to 8 weeks, once a week up to 8 weeks. Patient who had poor T-cell response, meaning low percentage of CD8 and CD4 together, less than 0.2% of CD4 and CD8 interferon producing cytokine, one of the cytokine producers looked at. 43 had poor T-cell response, and 12 out of the 43, or 28%, progressed to clinically significant CMV infection. Patient who had good T-cell response while on letermovir with low-level viremia, 0 progress and 0 needed treatment for their CMV reactivation. Now, off letermovir, after the 100 mainly, these patients, 28 patients, 12 had poor T-cell response, and 50% continue and progress to clinically significant CMV infection. And the 16 patients who had good T-cell response after stopping letermovir, and they were off letermovir, no one progressed to clinically significant CMV infection. We did a cost reduction analysis looking at CMV TCIP as time-dependent variables, and the outcome was clinically significant CMV infection for the total cohort, 85 patients. What we found, the independent predictors for clinically significant CMV infection were the type of cancer, they had ALL or MDS, the type of transplant, also haploidentical, the reference was other, total body irradiation, can predict, clinically significant CMV infection for the whole cohort, but also CMV TCIP test result. If they were negative, it predicted progression to clinically significant CMV infection after you control for many variables and factors in this analysis. Now, when we're interested to look at off or on letermovir. So the 57 patients who were on letermovir during the low-level viremia, we found also that total body irradiation was independent predictors of progression, but having a negative CMV TCIP, there was a trend out there, I think it has to do with the power analysis with the sample size, but you can see the odds ratio or the hazard ratio was pretty high, but it did not reach statistically significant. Now, we didn't do a cause regression analysis for patient off letermovir because the number, it was pretty low, 28 patient only, but that's what we, when we separated letermovir, we found a good trend toward progression if they had a negative CMV TCIP. When we looked at CD4 plus, CMV interferon gamma cells, and this is the median level between off and on letermovir, the one who had clinically significant CMV infection actually, off letermovir, they had a good median, CD4 cells producing gamma interferon, as you see here. If they were off letermovir, it will tend to be significant. And when we look at CD8 plus cells producing interferon gamma, we found that patient on letermovir, actually, it predicted better if they had no clinically significant CMV infection with a higher median CD8 plus gamma interferon producing cell. And this is the median that we show here. So this is the difference between the two, CD4 versus CD8, if they were on letermovir or not. So based on our preliminary data, so what we're going to do now, we're going to have a randomized trial looking at high-risk patients with CMV who make a CMV reactivation after day 90 and try to randomize patients to either continue CMV prophylaxis on letermovir up to day 200 or do interrupted letermovir prophylaxis based on the TCIP. This is an interventional trial. Try to answer the question, if you stop letermovir, if they have good T-cell responses, would they need again to be treated, or they will get CMV reactivation or not by doing the interrupted letermovir prophylaxis. So stay tuned. We're going to start the trial. It's going to be single-center trial, but we're going to start it soon, hopefully soon. So in summary, how to increase specificity of preemptive therapy or prophylaxis strategy is by combining monitoring of viral load or monitoring CMV specific T-cell immunity together. Probably at specific time mode could be helpful, but would this strategy allow withholding prophylaxis in the presence of CMV specific T-cell response? International data. In my mind, I think this could be a very helpful tool, but let's show it in interventional study. And what about withholding preemptive therapy for low-level viremia or moderate level of CMV DNA when you have a good CMV T-cell response? I think many studies, and we show you only one, but there's many others from our group and from others as well, as David went over it, that it could be helpful as well and could, at the best side, I think this question already answered in my mind, although some people would like to see more data. So I want to thank you for your attention, and thank you for having me today in this symposium.
Thank you, Roy, for your outstanding presentation. Now we're moving to the last speaker. Is Professor Oriol Manuel. I will introduce him in Spanish because it's Spanish. So, Oriol, muchas gracias por estar hoy con nosotros. Thank you for coming this afternoon here. Oriol es profesor de la Universidad de Lausanne, es un experto en patología infecciosa del paciente trasplantado, pero muy especialmente en citomegalovirus y también en la vacunación del paciente inmunocomprometido, entre otras neumococo, gripe, etc. Así como tiene numerosos trabajos publicados en la era del COVID en pacientes trasplantados también. La presentación de hoy va a ser sobre el papel de la inmunidad celular en el trasplante de órganos sólidos. Bueno, pues cuando quieras, os recuerdo que podéis empezar a hacer preguntas a través del chat y que al final habrá una conversación con los tres ponentes, todos juntos, con los tres temas juntos. Cuando quieras, Oriol, muchas gracias.
Muchas gracias, José María. Muchas gracias, David, por la invitación a participar. Y siempre un placer de participar en vuestro simposio. Supongo que veis la presentación y Ahora we'll switch to English to start my presentation. So thank you very much. So I will talk about CMV immune monitoring, which is the management of CMV according to the use of cell-mediated immunity assays. And so some of the fundamental ideas of cell-mediated immunity, it's common between stem cell and organ transplant recipients, but I think that the clinical application, the clinical scenarios, and also the data, the evidence, it's different. So probably we'll try to, in my presentation, to focus or highlight the differences on the use of these assays in the hematopoietic stem cell transplant arena and in the solid organ transplant arena. So here I will start with rationale for using CMV immune monitoring, because actually David has already gave a wonderful presentation. This probably will skip a little bit, but then as again, I will focus on the potential clinical scenarios this time in solid organ transplant recipients, because actually we have interventional trials that we show our experience on that. And maybe the last slide will be why we're not using widely these assays in the routine clinical practice. Probably we're going there, and probably I would say that in the coming month, we'll start using more frequently, but there's still some barriers, and then I will finish my presentation with that. So I don't need to talk about CMV. It's one of the most important opportunistic infections in the solid organ transplant recipients. Here, data from the Swiss transplant cohort. CMV is the most common viral infection after transplantation. And as has already been said, it's associated with direct and also immunomodulatory effects, so that the prevention of CMV is very important. Which I actually summarized the current, what I think for me is the current challenges in the prevention of CMV in solid organ transplant recipients. The first, it's we have still two populations within the transplant recipients that are high risk still for developing CMV complications. One is here, according to the CMV serostatus, you see that patients that are D plus or minus, so donor positive, recipient negative, still, despite all the prevention strategies that we're applying, there's still at risk for developing CMV disease after the discontinuation of antiviral prophylaxis. But also there are other groups which actually are doing very fine. And actually the risk for developing CMV disease is very low, independently of the strategy that we're doing. So actually, probably we can apply different prevention strategies according to this group risk. And then also by using lymphocyte depleting antibodies, so thymoglobulin, ATG, actually we're depleting all these important cells that are important for CMV control. And actually by using this assay, we increase the risk for CMV. So actually, the question is that all these clinical markers for a high risk are actually usually at the time of transplant. So we have the CMV serostatus at the time of transplant. We know whether this patient received induction therapy with thymoglobulin at the time of transplant. But however, most of these patients will not develop CMV disease at the time of transplant. We will develop later on. And actually, we don't have any clinical marker for deciding whether the patient will develop CMV disease at 1, at 3, at 6, or 1 year post-transplantation. So probably the big challenge now, the best challenge here is how we can dynamically stratify patients according to the actual risk of developing CMV at a given point, not at the time of transplant, but at the time that we're stopping prophylaxis, or at the time that we're stopping the preventive approach, or at the time that we have our first PCR coming positive with CMV. So I will skip this slide, only saying that CMV, so the response, of course, is using cell-mediated immunity, because we know in the immunocompetent hosts, it's a key control for CMV. And actually in the immunocompromised patients, actually, we can identify after stopping prophylaxis, which patient will actually control CMV or will not control it and go on, will go on and then develop a CMV complication. And also will not go, this slide's only to tell you that actually we can do, we can use these assays in the routine clinical practice, because now we have standardized assays. I will not discuss into the technical assays, maybe only one question is, How different are ELISpot and quantiferon? As David said, actually, there are very few control head-to-head studies, but actually looking at interventional observational data, we have the impression that actually ELISpot, as David said, it's much more sensitive. And also, I would say, maybe I will add that it's less influenced by immunosuppression, because we know that the quantiferon has a higher numbers of indeterminate results, in particularly in patients receiving, for example, ATG. Data from Marian Jose Maria has shown that. And that actually this is not happens with the ELISpot. Actually, I think that ELISpot is much more robust and less sensitive to immunosuppression, and that makes a very good stratification assay than the quantiferon. However, of course, the contrary is that it's much more cumbersome, and actually quantiferon, you can automatize the results and the performance of the assay, which makes much more easier to implement in the routine clinical practice. I think David and Roy have already discussed the clinical scenarios for hematopoietic stem cell transplant recipients. Here is the different clinical scenarios that can be also imagined on the use of this assay in solid organ transplant recipients. So as Roy said, in the hematopoietic stem cell transplantation, now actually most of the centers are using letermovir prophylaxis, so they're not using any more preemptive. But as you know, in solid organ transplant recipients, both preventive strategies, universal prophylaxis, which is the use of an antiviral since transplantation, or a preemptive approach by monitoring the CMV viral load, are, I would say, equally used. Usually universal prophylaxis for high-risk D+R- patients and patients receiving ATG, and the preemptive approach mostly in seropositive patients without ATG. But you can find a lot of variations according to centers. So in solid organ transplant recipients, some significant studies showing that actually you can better predict the risk of post-transplant CMV replication by actually using, on top of the serology, you can use a cell-mediated immunity assay, because actually some patients are seropositive, so a priori it's intermediate risk. Actually, if you have a cell-mediated immunity assay that is not detectable, then actually these patients behaves after transplantation as being seronegative. So it seems to be a good tool to better differentiate or better stratify at the time of transplant the risk for transplant CMV replication. I think the rest of my presentation will focus on this other clinical scenario, which is the to determine the duration of antiviral prophylaxis in patients so that are under prophylaxis in the post-transplant setting. I think that most of the studies and the interventional clinical trials I've done with this scenario, how we can dynamically determine or individually determine the duration of antiviral prophylaxis according to the result of these assays. Has already been discussed. One potential other application would be you have a preemptive approach, you have a positive viremia, in which case you will go on and treat with antiviral treatment, or you can wait because you feel that the patient on the immunity will control CMV replication. And also another potential is after you have treated CMV infection or disease, whether you need secondary prophylaxis to avoid relapse. So I would say I will focus on this in the duration of prophylaxis, because it's the only clinical scenario where a clinical trial has been performed, or others we have some data, but it's observational data, and then I will focus on this. So first, I will show the study that we published this year. This is a study from the Swiss transplant cohort. That is a multi-center on the 6 transplant centers in Switzerland that are collaborating in the Swiss transplant cohort study. And actually, this is a little bit the summary of the design of the study. Here we include the 2 groups of patients at high risk. So the high risk, which is the D+R- patients. These patients, actually, the idea is we randomize it either to a fixed duration of prophylaxis, which is the standard of care duration proposed by guidelines, or I'd say an immune monitoring arm where we give the first month an antiviral prophylaxis, and then under prophylaxis, we perform ELISpot test once a month. And then when the ELISpot is positive or above a certain threshold, we say that the patient has detectable immunity, it's controlling CMV, and it is the time to stop prophylaxis. And we did it stratified in the two groups. So of course, D plus or minus received the standard arm, received 6 months of prophylaxis, and we did 6 ELISpot once a month. And then we stop, and then we follow these patients. If the test was negative, then do continue until the next time point. And the same with R plus with ATG. The only thing that for this patient population, the recommendation are doing 3 months, so that we did 3 months as a control and then 3 ELISpots. Of course, all the analysis that we show you would have been stratified by serostatus, because the serostatus determine the duration and the incidence of duration of prophylaxis and the incidence of CMV. This was a non-inferiority study. What we wanted to show is that the incidence of CMV would be the same in both groups, in the intervention and in the control group, and actually a superiority, a co-primary endpoint of superiority, because we wanted to show that with the immune monitoring, we can reduce the duration of prophylaxis, so that we can individualize the duration of prophylaxis without having a higher risk for CMV disease. And this is the main result of the study. As I said, it was published this year in Clinical Infectious Disease. Here is an immune monitoring group. This is the control group, and And here you see that the first co-primary endpoint that was clinically significant CMV infection, as has been defined before, was either CMV disease or CMV infection that required antivirals. And you see that this was was similar, because the number of patients was not very high, the interval confidence, so we cannot add a statistically significant for non-inferiority, but we were very near. But you see that regarding the numbers, were very similar. Whether we use an immune monitoring or a control arm, the incidence of clinical significant CMV infection was the same. And also, again, so give you attention that actually it was very few cases of CMV disease, and all of this was mostly in D plus or minus, but the majority of patients that meet the criteria for clinically significant infection was actually treated as symptomatic replication. And then when we go to the second, so there was non-inferiority, and then in the second of superior, on the co-primary endpoint of superiority, we see that actually the days of antiviral prophylaxis, we saw a significant reduction in the duration of prophylaxis for approximately 1 month in the intervention group, in the immune monitoring group, with respect with the control group. Of course, as you can expect, there was a differences in the co-primary endpoints depending whether the patient was D plus or minus of seropositive. And you can see that there were not significant differences between groups. There was some difference, but actually there was not statistically significant scope. We were not powered to show differences in the subgroup analysis, but you can see in terms of CMV infection, there was not significant difference between the groups. And actually what we show is that actually the impact on the reduction of prophylaxis was much higher in the seropositive group. So in the R plus patients, we were, despite the fact that actually the control group is only 3 months and that we only performed 3 ELISpots, we had a much higher reduction of duration of prophylaxis than in the D plus or minus groups that, as I said, so was 6 months of prophylaxis, and we performed 6 ELISpots. And this is only, before I'm going to explain you the reasons of this significant difference between R plus and D plus R minus, it's only that also there is another study that I will not show here into detail that was performed by the group of Cordoba by Julian Torres Cisneros, that was also published in Clinical Infectious Disease 2 or 3 years ago, with exactly the similar design, but only in R plus patients. So, but this allows us, and using the quantiferon, this allows us to compare both studies only in the R plus population. And you see that we combine the study from Cordoba and our study. Actually, there was a very homogeneous and concordant, and we can actually confirm these results when we meta-analyze both trials in terms of CMV disease, in terms of clinically significant infection, and also in terms of days of antiviral prophylaxis. You see, when we combine, we confirm this this reduce in the duration of prophylaxis of about 1 month. As I said, I can explain you a little bit why this difference between D plus or minus, it's probably you can imagine. This is the result from one of the antigens included in the ELISpot, the most important, which is PP65. And you see in the D plus or minus patients, the CMV seronegative groups, as I said, we perform an ELISpot once a month. Here is the data about 1 year post-transplant. And you can see that actually only about 1/4 of all patients became positive and very late after transplantation, about 5 months after transplant. So that actually data that shows here that very few people were above the threshold for positivity at 5 months, which makes that actually at the time that you start having a positive result in patients that are seronegative, is the time that you stop prophylaxis because you arrive up to 6 months. So actually the potential impact of the use of these assays in this population, it's much, much lower because you will have very few positive and then very late on. However, when you compare of patients that were seropositive, and I remember here that actually all received ATG, so that apparently they have depleting lymphocytes and then the very low CD4, CD8 counts during the first month. Actually, up to 70% of this patient had a positive assay at 1 month post-transplant. So even if you receive ATG as induction therapy during the first week, even after 3-4 weeks, you will have a positive response if you are seropositive, which makes that you can imagine here that about 70% of patients stopped prophylaxis as soon as 1 month post-transplant, and this was increased, I think, about 75% or even 80% of positive at 3 months. So it makes that show you very clear that actually this is a population, the R+ patient, for which probably your intervention will be much more cost effective than if you use it in the high risk D+ or minus. So here's a little bit the summary of what I think that it's the clinical application of CMV CMI assays. So as I said, actually, the cell-mediated immunity assays in solid organ transplant recipient has a high positive predictive value. If you have a positive test, the risk of going and developing CMV disease is very low. So actually, when you have a positive test, you're quite confident that your patient will be out of problems about CMV. However, if you have a negative result, and then the predictive value it's much, much lower. So actually you cannot say anything. If your test is negative, probably you're at higher risk, but there will be a very significant number of these patients with a negative CMV assay that will never develop any CMV replication or any CMV disease. So this is probably still an open question whether we can have some more sensitive assays or whatever, but actually it probably is not a very good clinical scenario. So actually these assays where are positive, they identify the patients at low risk for subsequent CMV events. And I think that this is the main clinical application of this assay. And I can show you a little bit here visually what I think that it's the problem with that is not a problem, but it's the reality of that. Is here I put the positivity, the percentage of positivity assays, and here it's the freedom from CMV disease. Actually, the test works very nicely in very low risk patients. In R+ kidneys, probably 80-90% of these patients will have a positive assay, but this is the population where probably the risk for having CMV is very low. So that maybe, yes, you will identify patients, but probably what we can do in these patients is really, so you do nothing, you have a positive test, then you stop, everything is good. But you know that even if that the risk for having any problem is very low. I think the most interesting part is this intermediate group. So there are plus that have ATG, because this is probably the percentage of positivity you see is quite good. It's 70%, maybe a little bit higher if you're doing later on. But actually, if you're doing a 1 month post-transplant, 70% of your patients will have a positive result. And then actually, this is a group where we are quite, I don't know, concerned because we give 3 months, even some maybe groups of patients or a group of clinicians use even 6 months of prophylaxis. Can you imagine if you have a test that a 1 month post-transplant, if it's positive, and probably will be about 3/4 of your population, and you can stop, and then probably nothing will happen. I think that this is a very interesting population. However, when we would like to have some assay that will really help of managing our patients for CMV is the D+R- group, or probably the lung transplant recipients, because this is the group of patients which actually had problems, and then you need to see them, and they have relapse, and then you treat it, and then they develop resistance, refractory. Is really the group of patients that for which actually managing CMV is really challenging. But unfortunately for these patients, probably the benefit of using this assay, it's really low, because as I said, you will maybe 1/4, maybe 1/3 of your patients at the 1 year will develop some kind of detectable cell-mediated immunity, but it will not go up than that. So probably maybe help in a minority of these patients, but not in the whole population. And as I said, most of these patients will be negative. Some of them will have a lot of complications related to CMV, but some of them will do perfectly fine. So again, the discriminative power of cell-mediated immunity in these high-risk patients, it probably still needs much more studies. The thing that we're doing in Switzerland, with that I will finish my presentation, is actually we're like taking what we know now, the evidence is now, and actually what we're doing is in CMV seropositive patients with or without ATG, what we're doing is we're giving antiviral prophylaxis for 1 month. We do a cell-mediated immunity assay at 1 month, and then if the assay is positive, then we stop not only prophylaxis, but we stop monitoring completely. We don't do PCR, we don't do anything. We forget about CMV in these patients. If the test is negative, then we continue the standard prophylaxis of 3 months. So we started with that last year. Now, of the 6 transplant centers in Switzerland, there are 3 that are using these assays. The other 3 probably will join in this year, with problems for implementation of ELISpot as the main reason for the delay. And I can say on the first almost 100 patients, we have seen very low. We have seen like 80% of positive results and very low CMV disease rates. So probably we'll try to show you our experience in coming meeting next year. And I finish with that. So one of the questions of why it's not been routinely used is because we need clinical trials. I think the clinical trial is what give us the evidence for implementing and what is the added value of this assay. And probably there has been some clinical trials, probably we need more than that in different clinical scenarios. Most of the data I show you it's in kidney transplant recipients. Probably I think that there are trials in lung transplant recipients that will come out in the next month. As I said, we don't have enough data comparing ELISpot and quantiferon. And also most of the studies have shown CMV infection. Probably we need more data about CMV disease in different transplant populations. So basically what we need is probably more clinical trials. And then also studies that show that implementing this assay is cost effective and it's doable. And I think that probably our study in Switzerland will probably advance that, and we show which is the feasibility and how this works outside the setting of a clinical trial, and how does it works in the routine clinical setting. So this is my slide of conclusions. So I don't think that I need to read out, and then I'm happy to answer some questions if you have some. Thank you.
Thank you, Oriol, for your wonderful presentation. So I don't see any questions in the chat.
Una
Do you see?
pregunta.
Sí?
We have a hand raised. Is Francisco López Medrano.
Okay. Sorry, I didn't see it.
Okay. Francisco, puedes hablar directamente. ¿Sí?
You can talk, but you're mute.
Estás mutado. Bueno, si no podemos ir mientras Francisco.
Sí. Yo no sé cuánto rato tenemos, José María.
Pues como 10 minutos máximo.
Vale. ¿Empiezas tú preguntas tú algo?
Bueno, sí. My first question could be for both speakers. The question is either in solid transplantation and also in hematopoietic stem cell transplantation, is have any sense at this time to use close time for the prophylaxis with the thermovir, so 200 day or 100 day. I think to be necessary to implant in our hospital the use of CMI or T cell response because the time is obviously is marked not for the time, the close time is completely independent of the cellular response. So what do you think? Even in the clinical trial, I think that this new method could be implanted in the clinical trial also. So my question is, have any chance to close a time for the prophylaxis in both type of transplantation, or we have to forget this close and expand the use independent of the response for the T cell response?
So maybe I can start by saying, so the question is if we can use the CMV-CMI when patients are on letermovir prophylaxis and help us guide us when to stop. Is it at day 100, day 200? I don't know if this is the question. I would say, this is what we're trying to do now in our intervention study, that, when you get to day 100, we look at patient profile, and is it really only the host? We look at some risk factors for late CMV infection, but we know it's not very specific. And not that sensitive also, because also, as Oriel mentioned earlier, even if we have negative CMV-CMI, not everyone will reactivate. So there is other pathway that we don't understand well that may be protecting patient other than looking at interferon gamma assays or other, maybe other pathways that can protect patients. But I would say when patients are on letermovir, having this kind of tools, it will help us in a way to tell us if they have a good CMV T cell response, then we can stop and monitor and see what's going to happen. It could be any time after the 100. If you're on high dose steroid after the 100, I think it's useless to do this study. I totally agree. I think David mentioned this when you have patient on steroid. But this is a low hanging fruit. I hope we can get some data to show, because then we can shorten the duration or extend the duration for patient who really needs it.
In solitary transplant recipient, I'm not sure which would be the role of letermovir. So I'm not sure what are you doing in the US or in Spain. Here in Switzerland, we're still reluctant to use it widely in D plus or minus, obviously for a cost reason. And because we have a long experience with valganciclovir, and actually valganciclovir is less toxic than in stem cell transplant recipients. But actually, I think that your question is very relevant, because if we decide because of commodity, because it's less toxic, because we don't need to adapt for kidney function, and we decide to use letermovir to everybody, or there are some more data showing that it's beneficial to use letermovir, I think that actually the cost effectiveness of using cell-mediated immunity, it's so great, because actually, I don't know, for the R plus patients, if we think 3 months of letermovir is like 30,000 euros, something like that. If we can avoid 2 months of prophylaxis, I think that's really cost effective. And I think that maybe the letermovir era, it's even more significant to use these assays and to individualize the duration of prophylaxis. But I think, as I've said, and also Roy said, these D plus or minus patients, it's a difficult population, because, as I said, so Some of them will never develop cell-mediated immunity. And then if we need to be based on this assay for continuing or stopping prophylaxis, it may that some patients will actually prolong prophylaxis, which is exactly what we do not like to do in this setting.
Yeah, well, there is one thing that I would like to comment on. It's the fact that we are probably focusing too much on T cells exclusively. So probably we won't get any further just by taking a look at T cells. So we probably should incorporate other parameters just in addition to T cell assessments, just to be capable of predicting more accurately whether the patient is going to go to ahead and develop clinical significant infection or not. So probably we are, because after 20 years of these tests, more or less, or 15 years being used, there are just a few clinical trials. I don't think we have made a giant leap forward, actually. So that's the thing. I believe that we should probably combine T cell assays results with other immunological parameters, just because the immune response against CMV in highly immunosuppressed patients is quite redundant. So probably there are other mechanisms that, in the absence of T cell responses which are effective, operate to avoid the development of CMV complications. I don't know how you see this approach.
That's a great point, David. I totally agree. I think the T cell assays in specific situation and scenario may help, and we show that. But in general, as the overall, you're right. We're still missing some other determinant of CMV reactivation or risk for CMV that we're not measuring yet. But combining other, what do you think about TTV? Maybe, I don't know. That no one looked at TTV.
Yeah.
I know it's an organ. You look at it more often, but in stem cell even, the combining both, would this help us? I don't know.
Yeah, why not?
Yeah.
And probably NK cells, for example, NK cells which expand upon CMV infection, which could be easily measured. And we are planning to do some studies just focusing on that, on the performance, on the predictive value of combining different immunological parameters to predict clinical significant infection in the allo recipient.
I think there are two aspects. One is how you can better discriminate or prevent or predict the risk for CMV replication, CMV disease. This is one thing. The other thing is how you can implement it in the routine clinical practice. I feel that with the R+ without ATG, I think T cells assay that we have commercially available, I would say they are good enough. So as I said, it's 80% positive. You stop, we'll have very few. So if our data is confirmed, I think this is already something that the clinician may use in the everyday basis, will be happy that they say, I give only 1 month of prophylaxis, I do the test, and then 80% of my patients, I will not need to have any concern. For the R+, I think it's good enough. Probably it's not perfect. Probably we'll still have some kind of CMV disease maybe after, but I think that it's something that it's reasonable. It decreases the intensity of monitoring and everything. I think it's something that's clear cut. But then actually you have the D+ or minus, for which is probably 20% of our transplant population or the lung transplant recipients. And then in these patients, probably, as you said, T cell therapy, T cell assays are not enough. Maybe we need to combine because these patients, they're still, we have concerns, and maybe we'll spend a lot of time following these patients. And maybe for these patients, we're happy to have more assays done or combine some prevention strategies, or as I said, so looking at NK cells or looking at gamma delta cells or combining TT virus, because these patients are otherwise, if we do nothing, they end up with severe disease or other. So I think that for this very specific population, we need to do better. For the 30%, 70% of R+, I think that we have a good compromise of a relatively good test and a simplified way of following these patients.
Well, that's the thing, that we need good scores for people at highest risk. and we don't have them. So that's the
Exactly.
thing.
Exactly.
So Maria?
I have a question for Oriol. Have you shown? I think it's very clear that the big problem at this time in solid organ transplantations is lung transplant recipients with plus minus situation. In this patient, this is practically impossible to in some cases to feel free of the virus. Do you think it would be reasonable to let these patients who have some grade of low viral load or something, because we insist to treat these patients generally with obviously, because we cannot use Foscarnet, we have not experience with letermovir, so continually provoking with ganciclovir. Maybe twice to let something of respond to.
I think for the D plus or minus, maybe you have two things. One, that I think that there is no studies, and I could do some advertising, but now there is a European cohort led by Bordeaux and with an European project that's looking at really all the immune mechanisms in a cohort of solid organ transplant recipients. And actually the idea in R plus, in D plus or minus, and the idea there's some studies that show that about 30% of D plus or minus patients never develop CMV viremia, never seroconvert, and never have a positive ELISpot CMV, which makes that actually when we talk about D plus or minus, of course, the majority of them will reactivate and had a lot of problems, the clinical situation you said, but maybe there's 20-30% of D plus or minus, which are actually not D plus or minus. And actually they are D minus or minus because we'll never reactivate CMV. And I think that if with this study, we can identify which patients that are the donor are seropositive, but will actually CMV will, maybe it's not in the kidney, or even if it's in the kidney, will never reactivate. Maybe it's some kind of latent virus that will have no the possibility of reactivation. I think like that we can better stratify the D plus or minus in the real D plus and the D plus or minus that are behaving as a D minus or minus. It's with that, probably we can maybe reduce a little bit the percentage of patients that are really at high risk. And once that, I think that you are right. I think that the only thing that will cure CMV, it's the cell-mediated immunity. I think that one of the things that we can do is allow low-level replication. And in my clinical practice, what I'm trying to do is I increase the threshold for treating patients depending on the number of reactivations. Of course, the first reactivation in D plus or minus, I will have very low threshold, we'll treat almost immediately, and then we'll give some kind of secondary prophylaxis, and then the second episode, we will probably increase a little bit the threshold, we'll allow a little bit longer replication, and then in the third episode, we'll try as much as possible to not treat, and then we'll really allow very high thresholds for CMV viral load. And with the idea is actually allowing some kind of CMV cell-mediated immunity. Of course, there will be always a group of patients, very high risk patients. Probably these patients, it's something that it's promising for the last 30 years also, it's the use of T-cell therapy. Maybe now there are studies using gamma delta T-cells, which it's probably interesting because it's like pathogen agnostic and with the need to adapt to the CMV. So I think that there are some possibilities, but my idea is try to allow the mounting of a cell-mediated immunity by trying not to treat. Of course, we need to think and then follow these patients and then convince the pneumologist or the nephrologist that probably some kind of replication is not really bad, but I don't see any other, unless we give T-cell therapy, I don't see any other way of dealing with that. Then the ELISpot can be helpful because if you have a very positive T-cell response at that time, probably you also will be confident that maybe you don't need to treat all CMV replications, maybe.
We should
So one last question for Roy, for example. So Roy, how far are we from using these methods in the allogeneic stem cell transplant setting? Because I'm not sure whether Oriol, you are using it in real life.
Yeah, we're doing this study. That is an implementation study. So all our patients are plus kidneys.
Okay.
We have an ELIS spot every month. No, but not every month. At 1 month post transplant, and if the ELIS spot is positive, we stop everything.
Okay. So Roy, what do you think?
Yeah. So I would say in the US, based on my talk to many cancer centers and other centers who also have solid organ transplant, we have one commercially available test, and it's probably underutilized. But some people have started using it without looking at the data, without having interventional data. And actually, I told them, I've been talking to people, let's put real world data out there to see, did it help you when you order it or not? So this is number one. Number two, I would tell you my institution, because now it's available for us over the past 1 year, and it's been ordered left, sporadically, I would say. But after I finalized the analysis on the low-level viremia and start the intervention trial for letermovir, I'm gonna go and have a SOP for our transplant, allotransplant people, that in this situation, let's order it. It becomes standard of care. This is my plan, because unless you start using it in real world and look at the data, see, did it help you or not, it's gonna be far away. If you're gonna wait for like 5 international intervention trial, it's not gonna happen.
Yeah.
It's not gonna happen soon. So this is my plan. I'm gonna start step by step, specific scenarios, use it, and let's look back and see if it did help us or not.
I fully agree with you, Rob, you know that. So I don't think we have more time to go. So it's time to say goodbye. So I would like to thank again Roy and Oriol for joining us today. It's been a great experience to have you both around, and hopefully we'll have the opportunity to cooperate again in the near future. And por supuesto, gracias a MSD y a doctor Aguado, actualmente, y a toda la audiencia por estar ahí. Solo lamentar que ha habido gente que ha querido intervenir, Francisco, creo que Mario también, Mario Fernández, y no han podido hacerlo a través del chat, no sé exactamente por qué, pero en fin, en cualquier caso, gracias a todos por estar con nosotros hoy. Thank you, Roy, thank you, Oriol, thank you, José María, and see you soon.
Thank you.
Muchas gracias.
Thank you very much. Bye, Roy.
Bye-bye.
Very good. Have a nice day.